Hello and welcome to Filibusters in Fine Print, where AMGA's public policy team gives you the insider view on healthcare regulations and legislation. Thanks so much for joining us for the latest from Washington, D.C.
Good morning and welcome to Filibusters in Fine Print, AMGA's public policy podcast. I'm Chet Speed, your host, and I'm here today with the best podcast crew in the business. Why don't we start with the folks on to our left today?
Jamie Miller, Ambassador Goodwill here at AMGA.
Alicia Sawyer, Government Relations Assistant.
Hi everyone, Daryl Drevna, Senior Director of Regulatory Affairs.
Hi, more likely I figured out what I do. I'm Director of Government Relations here at AMGA.
Yes, you are. Nice. And we're here with our...
Good job.
Good for you.
We're happy to have you.
Real progress.
Take that, memory.
And we're here with my guy, the best producer there is, at least in this room right now. You're good. We have a question. We have a question for us. So for those of you who don't know, DC has been socked in with cold temperatures and snow and ice called snowcrete, a term created by Lisa Sawyer, our GRA.
As far as my parents and anyone else is concerned, yes, I made up this term.
And absolutely copyright lisasawyer.com. So the question is, how did you all get out of your houses this week?
Well, I'm going to say something potentially controversial, but if you're ever in a snowstorm, find somebody that drives a Subaru and ask them how to do it, because people from the Pacific Northwest know what they're doing. I randomly had a neighbor. We had like 5 inches of ice and our cars were stuck in it, and she just got the back of her hammer. It was just cutting through the thing, and so I started doing that. And as a Southerner, I had no idea. So thank you, Subaru people.
So you used a hammer to hack out literally 5 inches of ice on your... Good.
Yeah.
Okay. And you are from South Carolina?
Yes.
Yes, sir. Okay.
Yeah, we don't have ice or snow or anything.
Stuff like that.
In the South.
Yeah, I'm also from a place with no ice or snow, and so I went back there.
Publix. You went to Publix every day, right?
Yeah, I evacuated to Florida.
That might be the best idea.
Yeah, my mom was apologizing because it was so cold. It was 60. I was happy.
We went to a lacrosse game. It was -4 Saturday morning.
No, thank you.
Daryl?
Oh, me?
Yeah, please.
Well, let's not all be shocked that I had 50 pounds of ice, industrial snow blower, and garden hoe to break it up. So we were fine.
Of course you were.
And you also
salt. I said ice. I meant salt.
And you have a Subaru.
Salt.
So
I do have a Subaru.
So you know what you're doing.
That's right.
So ask Daryl when you have a snowstorm.
And you said, you know what, it's not cold enough, I'm going to Minnesota.
Exactly.
Is that right, Tim?
I spent a trip with the Scouts, 2 nights on the ice. I don't think it got above 10, 15 degrees while we were out there. Slept with the sled dogs, and it was a great time.
I bet it was.
Yeah.
For you.
Yeah.
Ms. Latney?
I live in an apartment, so a lot of the manual labor that comes with that is paid for by my rent. So I really appreciate that. I did have to go out to the bank, and that was awful. Just trying to survive. I have my comfy snow boots on still to get me there, and I just felt bad because I was talking to a committee staffer, and then she watched me strip down to 8 layers to get through security, and I was like, I hope I never see her again because I'm embarrassed for me. But yeah, I mostly cocooned and waited for the apartment complex to do what they did.
But didn't you say in a metropolitan area, it was shocking?
Oh yeah, I texted Jamie. I was very indignant about this. I was like, how could we live in a major metropolitan area and just have such terrible snow removal? Well, that's why I'm moving out of the city. I think I've become that person people talk about how much they hate.
Alexander's worse also.
I know, but don't tell. I'll experience that when I get there.
And the city would fine you if you don't clear your front sidewalk. But the mayor came out and said, we're not going to do that this time. And I'm like, no, you should find people.
You should probably.
I would have doubled it.
You just because you go 2 doors and all of a sudden you're on the ice.
Yeah.
Yeah, and never seen anything like it in
What would you do?
All years. Well, let's see. We I'm a former firefighter.
How's your voice go down an octave every time you say that? Hero.
So I got out. Yeah, FKA, American Hero. And so I took an axe and I had a great time. I axed out my driveway. I axed out my father's driveway. So I had
Did you go through the ice? You think you got some pavement problems maybe after?
There's pavement problems. It'll be unhappy days when the snow clears.
Your wife's like, what did you do?
A little chipping on the flagstone. But it felt good.
I don't know. If I was your neighbor, I'd be like with my cup of tea and like, what is this fool doing out here with his ass?
You nailed. No one did their driving except for me. Nobody.
That's funny.
All these rich people hanging out doing nothing, and they're whatever BMW anyway. I get class conscious. Okay. All right. Well, today we have actually this may be the meatiest topic we've had ever. I think
that's what we've been stalling.
Yeah.
So today we're going to talk about Medicaid and one rule and one sort of advice memorandum from CMS regarding some dramatic changes to Medicaid provider taxes as well as Medicaid state-directed payments. And this sort of follows after the passage of the OBBBA in July 4th, I believe, which included provisions that cut essentially $1 trillion from Medicaid. So CMS is now coming out with regulations that implement part of that, but also regulations that go beyond what was in the OBBA, particularly as pertains to provider taxes. So this is going to be a very, very, very meaty, but I think really educational podcast for the members. So I tell you what, why don't we start with Alicia, and why don't you give us some stats around Medicaid as a whole?
Yeah, I'm happy to provide some background here. 80 million Americans are covered by Medicaid, and that accounts for about 19% of national health expenditures. That makes Medicaid one of the largest payers in the U.S. health system, on par with Medicare and private insurance. It also means that Medicaid isn't just a benefit program, it's the foundational infrastructure of the American healthcare system. And in that sense, I kind of like to think of Medicaid as sort of like the Atlas of the system. I don't know if you're familiar with Atlas, but he's the Titan in Greek mythology who carries the world on his shoulders. And so the way I like to think of it is like the shoulders of the program carries the entire healthcare system. You've got the shoulders, which is Medicaid as a physical infrastructure, the safety net hospitals, rural health clinics, nursing facilities, the people that serve the entire community. And then you've got the muscles holding the body together, and that's the workforce. Medicaid funds graduate medical education, supports community health workers, sustains rural providers. And then you've got like the circulatory system, which is Medicaid's financial infrastructure. Don't worry, it's getting good. I know, I'm building up. And so the financial infrastructure that enables health systems to serve their diverse patient populations by providing baseline revenue stability. And so this financial framework, the circulatory system providing, everything the body needs for the shoulders to carry the weight of the system, it helps us understand why these recent policy changes matter so much, because they affect the entire system's foundation, not just the beneficiaries of the system.
All right, fair enough. I think we all agree. So Jamie, what's driving these changes right now?
So there's a lot of conservative sentiment from various think tanks like Paragon, Heritage Foundation, and a lot of these organizations have impacted Project 2025. It was last year about the Trump administration. And so these think tanks have sprinkled their people and their influence in the Trump administration and the committees of jurisdiction all over Congress. And they've basically flipped the script on us and talked about, instead of how Medicaid is, as Alicia mentioned, helping people, it's talking about how the financial structure is creating perverse incentives. It's also, they're using the term a lot about legalized money laundering. These terms have not been used before and Common Company, just started a couple years ago. I just talk about the influence of these organizations. AMGA testified a couple years ago about MACRA, Medicare Access to Reauthorization Act, and it was 3 doctors, someone from Harvard, and then someone from Paragon. So these Hill staffers are listening to these organizations and thinking that they're being better stewards for the government funding. But there is just a lot of talk about how Medicaid is being improperly financed and giving the wrong incentives and potentially being improper payments. And so that's kind of what, especially the Republicans, are hearing from these think tanks.
Okay, so essentially, Medicaid costs too much, and conservatives and others want ways to reduce the spending we spend on Medicaid. Is that
correct?
Okay, all right, great. So why does this matter for AMGA members?
Well, they also talked about like Medicaid had improper payments of $1 trillion. And why this is important is because if you remember in the OB3, there was over $900 billion in Medicaid cuts. So a lot of the work from these organizations led to a lot of these cuts. But the script is being flipped. I would say from Lauren and Alicia and I, when we go to the Hill now, there's a lot of talk about, hey, what about this? What about this money laundering? Or what about, why are these hospitals doing these things? And we're saying, well, actually, hospitals are doing good things for patients. And if you actually cut Medicaid and you do these reforms, quote unquote, you're not just going to hurt Medicaid recipients. You're going to hurt the middle class. You're going to hurt because people are going to have trouble accessing clinics because clinics are going to be closing, physicians are going to be fired, and also services like telehealth may discontinue. And so that's been our charge, is letting people know and the policymakers understand that Medicaid is much broader than just a system for certain disenfranchised people. It impacts the entire healthcare system, and that's where you come in and helping us share that message.
When you say you, do you mean me or the members?
Everybody.
Okay, great. Okay.
All of us.
All right. So that's the broad look. Let's get a little more specific. Let's talk about provider taxes. I think Lauren, you're up for this. The funny thing is when I was on the Hill in 1991, we talked about provider taxes. This issue's been around for a very, very long time, but this is the first time something's been actually done to them. So what are provider taxes? And give us a tutorial.
I feel like provider taxes are the symptom and not like the cause of the disease. The cause being that we do not finance healthcare fully like we should. And so while states can like use general funds to do a state match for Medicaid, they also assess taxes on healthcare providers. These allow the states to tax healthcare entities and then use those revenues to draw down federal matching funds for Medicaid. The taxes must be broad-based, uniform, cannot incorporate a hold harmless arrangement to be eligible for the federal financial participation, and CMS has the authority to approve these waivers for broad-based and uniformity requirements if the taxes are found to be generally redistributed. The most recent CMS regulatory and sub-regulatory actions have sought to kind of clarify and tighten these rules of permissibility around provider taxes. Provider taxes really became like a boogeyman last summer, in early spring of last year, talking about, well, this is probably the causes people are gaming the system. And nearly all the states, 49 states plus DC, use provider taxes as a financial mechanism. You talked about like, this was around when you were on the Hill. This was around when I was on the Hill. This was touted by Georgia as a really positive thing, actually, because it helped fund children's hospitals. And so to kind of see the pivot is very interesting to me. And so that's kind of been like a lot of the conversation over the last year.
All right, fair enough. And so why would an AMGA member care about changes to the provider tax structure?
Like I mentioned, like in Georgia, this was like a thing that actually kind of supported children's hospitals. They become integral in financing strategies, particularly for hospitals in states with Medicaid expansion. If their medical group or affiliated entities are subject to these taxes, it directly operates their operating costs and margins, because states use provider taxes to generate their share of Medicaid funding, draw down additional funding, and also use this revenue to increase Medicaid payment rates. Also saw this, a lot of states, a lot of people who had special needs were getting higher reimbursement rates for being cared for. Higher provider taxes mean that better Medicaid reimbursement for group services, which is really significantly matters if they're serving a substantial Medicaid population, which we've seen.
I agree. And so these provider taxes have been around for a long time, as we've firmly established. And just recently, the Trump administration finalized a rule that they say closes a massive loophole that's been costing taxpayers $78 billion. And so, Daryl, what is this loophole, and how do the states exploit it according to them at least?
Sure. So this loophole in CMS's framing is states taking advantage of the statistical test that's buried in the Medicaid regs that allow these states to impose dramatically higher taxes on Medicaid businesses while technically passing muster with federal regulators.
So, Daryl, are you talking about the B1, B2 test, which CMS used to determine if a state's non-uniform or non-broad-based healthcare related tax is generally redistributive, and approval for a waiver?
Well, actually, yes, I am.
I know, we need like this sitcom background of like people clapping.
Yes. Laugh track.
Oh, I was gonna say, I thought it was like, how did we get to this place? Like, you might ask me.
We got this because it was in the script.
It was in the
And
script.
it's bolded.
It's
and
bold.
italicized.
Quotation marks.
Yes.
So yeah. So
So
but
no,
it's good.
yes.
Yeah, it is. It's a formula that's in the regulations, and states would impose taxes on healthcare providers, but structure them in a way that Medicaid businesses were taxed at dramatically higher rates than other businesses. And this B1, B2 test that that Chet referenced you have to pass this to see if they're generally redistributive. But the test has a loophole in it. States could design the taxes in a way that technically pass the test while still hammering Medicaid businesses at much higher rates. So the way this works, the old test looked at ratios and averages across all providers. So states figured out that by carefully structuring their tax groups and rates, and they mostly did this by excluding a few large providers from the healthcare related tax, they could pass the CMS test. So effectively, the states figured out a way to make 2 + 2 = 5 on paper, even though everyone knew exactly what was really happening here.
All right. And how common is this?
CMS identified California, Michigan, Massachusetts, and New York as among the 7 states with tax programs that are considered problematic. In a fact sheet that it released, CMS asserts that these 7 states impose higher taxes primarily on the Medicaid business of managed care organizations, although one such tax is on hospitals. 7 states were also primarily using this loophole, with the current loophole generating about $24 billion in revenue.
Yeah, and this basically is states tax providers, and they return those dollars to the same providers. It's a cycle, and it has been compared by certain conservative groups as money laundering. But all this is designed to draw down increased federal Medicaid dollars. And one thing some states have done is, like as Laura mentioned, the hospital bed tax is an example of this. Certain states have done that.
All right. So this new rule was supposed to fix all that, right? So, Daryl, what does it actually do?
Yeah, I think if you sit down from CMS's perspective, they fixed the glitch. If
one of our best movies.
Office Space, love it. Yeah, whoa, like we just fixed the glitch. So it does 3 things. It basically prohibits 3 types of tax structures. Number 1, no direct Medicaid penalty. States, you can't charge a higher tax on Medicaid businesses as compared to your non-Medicaid businesses. So if you tax an insurance company $200 for each Medicaid patient they cover, but only $20 for each private insurance patients, that's a no-go anymore. Number 2, no tiered penalties based on Medicaid volume. So you can't create a tax bracket where providers who serve more Medicaid patients pay higher tax rates. So say you're a nursing home with 40 Medicaid patients per day, that pays $200 per day. Those with 40 or fewer pay $20. You can't do that anymore. The third rule here is no disguising Medicaid-based taxes. So you can't use creative language like, we're going to tax hospitals $10 per patient, or $10 per discharge for patients for those who are in a, quote, joint federal and state healthcare program, but only $5 for other patients. So there's some exceptions to that, but by and large, those are the 3 rules.
Okay. And so what does this mean to states and our AMGA members?
States are going to see huge decreases in federal Medicaid funds, and they'll have to find new resources elsewhere or be faced with difficult decisions. A lot of this funding is drying up. CBO released an estimate that the changes in OBBA would lead to Medicaid funds and federal net spending decreases by $226 billion over the next decade. And the bulk of that savings is coming from the moratorium and new provider tax prohibitions and reduced limits in expansion states. And at least 31 states are going to need to reduce provider taxes, and 7 states are likely to be impacted by changes to the agency's redistributive test. And so for AMGA members, hospitals that benefited from supplemental payments funded through these taxes are going to face potential revenue loss as well. Many safety net hospitals structured their financial models around these payment arrangements, and so they're going to need to figure out what comes next. States like California, New York, Massachusetts, and Michigan, as mentioned, they account for 95% of the revenue from these. 95% of their revenue is from these relationships, and they face the most significant disruptions as a result.
All right, and so you have the OBBA, which is going to reduce your provider tax rates over like 5 or 6 years. This is on top of that also. So we have the OBBA changes, then we have the changes in this final rule as well. So the impact is probably even more dramatic.
Correct.
Than just if the OBBA existed in isolation.
Yep, I think that's fair to say.
Okay. All right, so some really dramatic changes to Medicaid going forward. Well, speaking of more dramatic changes, state-directed payments. There are new limits and what that means. That's a different financing mechanism, but they're also getting squeezed by these new rules. Daryl, can you touch on what the new advice is around SDPs and why do states use them?
Yeah, so state-directed payments are a way for states to tell private insurance companies, effectively, Medicaid managed care plans, how much extra money to pay hospitals or other providers on top of their regular rates. So, if you're an insurance company deciding what to pay a hospital, the state government can come in and say, you must pay, hospital X an extra $10 million a year. This is effectively a way for states to ensure certain providers got adequate funding. They had given up some control when they shifted from fee-for-service into Medicaid managed care. Mm-hmm. This is a way for them to sort of claw back some control and really direct funding to certain providers.
Indeed. Okay, so under the OBBA, when it comes to the state-directed payments, we're talking about $100 billion annually, these payments. That's a huge amount. And so what exactly changed under the OBBA when it comes to SDPs?
Right, so
that's a lot of acronyms.
That's a lot of acronyms. Yeah. And effectively, we're reducing the state-directed payment total payment limit rate to 100% of Medicare for those states that expanded their Medicaid programs as part of the Affordable Care Act, and 110% for non-expansion states. So it's a little bit of ACA politicking going on around here. The previous limit was based on average commercial rates, typically 2.5 times Medicare rates for hospital services. So this is a dramatic reduction in allowable payments here.
Yeah, exactly. Okay, but there is grandfathering.
There is. You ever watch that show 24 with that big countdown clock?
I read books.
No.
All right.
Okay.
Right.
You
Nobody
guys are
knows.
just talking about movies and TV shows. All right.
Right. All right. So
I'm a scholar and a firefighter.
Fine. All right. So there's a big countdown clock, and there's a grace period here. These grandfathered state-directed payments get protection only until January 1 of 28, so less than 2 years from now. And there's a really aggressive phase down, 10 percentage points for each year. If a hospital uses that grace period to prepare, the cuts are still going to come. So this grandfathering really isn't a salvation. There's still like this ticking time bomb there. And CMS said in the sub-regulatory guidance that they issued, they expect to do some rulemaking around there. So more to come on, state-directed payments and the phase out, or phase down, I should say.
So there must be a rationale for all this.
Yeah, so what CMS is seeing is states using provider taxes to generate the state share for state-directed payments, and then using STPs to pay providers back for the provider taxes with federal matching funds added. And so what the federal government saw was this is money laundering, while states saw it as creative financing. And so CMS Administrator Dr. Oz is quoted saying, "The goal is to protect Medicaid's long-term physical integrity while ensuring STPs remain sustainable, transparent, and fully aligned with our mission to protect beneficiaries." So in summary, the administration's position is to reduce federal spending and prevent states from using overly generous STPs.
And I think some of these conservative think tanks, as you mentioned, when you talked about money laundering, they've used terms like corporate welfare, saying that STPs are corporate welfare for large hospital systems. And if you talk to any provider in America, profit and Medicaid don't go together. These people, these populations are never high-paying payers. And so to say that is very laughable. But with this SDP reform, some states are seeing billions less in reimbursement, which leads to less access. And so it's definitely a complex explanation for us to tell the Hill. But if you're from a state, I'm not going to say which state, but certain states have seen billions of dollars less in reimbursement because of these changes.
Okay, so the capping payments, some folks are calling this corporate welfare. Lauren, will you sort of walk us through what it means in real dollars to a typical safety net hospital?
Yeah, I just feel really sad right now. I mean, like, this is an incredible cut to this program, and like it's the patient impact is going to be, oh my gosh. So it's basically just fundamentally like restructuring how billions are financed through Medicaid. Like a hospital receiving $50 million annually in state-directed payments at 250% of Medicare would see payments drop to 20 to 22 million with a loss of 28 to 30 million dollars. You're going to see this a lot in Texas, California, Florida, and New York, which have the largest state-directed payment programs. So the pain is going to be concentrated in specific states and healthcare systems. Academic medical systems will also really be impacted by this because they are particularly dependent on state-directed payments. Safety net hospitals in urban areas are also structured around these enhanced payments. So it's hitting a large group of vulnerable populations.
Indeed. So what are the strategic implications for AMG members on this?
Our CFOs will need to restructure their revenue projections and potentially cut services. Medicaid margins, which have been historically thin or negative for many providers, will worsen significantly. Hospitals may need to reduce Medicaid patient volumes if payments don't cover these costs. Some may exit the Medicaid managed contracts entirely. Academic medical centers face particular challenges funding graduate medical education without state-directed payments. So future doctors are going to have problems getting funded. It's a lot.
Okay, and so some serious implications for AMG members going forward. Okay, we are at 27 minutes, so we're going to wrap this up. We're wrapping it up because Daryl said we had to wrap it up, and he wants to be the last person to talk. So Daryl?
I do, yeah. So I think, to Lauren's point, the team's point, this is the changes here are gonna ripple through the entire healthcare system. So the next, 18, 24 months are gonna be critical as the implementation of these rules and guidance unfold. And that was a whole lot of information. We're gonna be doing a webinar on both this final rule and the sub-regulatory guidance on state-directed payments on March 5 at 2:00. So if you want the nitty-gritty on both of these things, join us for that. There'll be registration going out soon.
Okay, great. We spent 30 minutes on this and this Medicaid topic, and this is just the beginning. So to our loyal listeners out there, we're going to be talking about Medicaid a lot over the next 2 years. So stay tuned, and thank you all for listening, and have a great day.
Thanks for joining us for Filibusters in Fine Print. This podcast was brought to you by AMGA. For more information about AMGA's advocacy efforts, visit amga.org/advocacy.